Health Matters. I'm Barbara Myers. On today's show, we are going to focus on Obsessive Compulsive Disorder, or OCD. Here with us today are two people who have seen firsthand how OCD affects the lives of people living with it. Jeff Bell is a newscaster at KCBS Radio in San Francisco, and he's also the national spokesperson for the International OCD Foundation. He is living with Obsessive Compulsive Disorder and has recently written 2 books about his experience and about a program that helped him and others to recover. Welcome, Jeff.
Thanks so much for having me today.
Dr. Joseph Racklin is a psychologist at Kaiser in Union City. His specialty is working with people with OCD. He has been running a treatment group for OCD for several years and is on the Regional Best Practices Committee for Anxiety Disorders. Welcome, Jeff.
Thank you for having me as well.
I'd like to start talking with you, Jeff. Can you start by telling us some of your story in your own words? When did you first realize that there was something wrong?
I was probably 7 or 8 years old at the time, and I certainly didn't know it was OCD at that juncture, nor did my family. But I remember walking along a busy street with my sister and mother, and a car drove by, and somebody I obviously know rolled down the window and shouted hello to me, another kid. And I couldn't figure out who it was, and I became fixated on that. And that night, and for many nights to follow, I found myself doing what I now know to be mental checking, in that I would rewind, replay, and repeat, if you will, these virtual sequences of the car driving down the street. I could see that clear as could be. I could hear the kid yelling my name, but I could never quite figure out who the kid was. But I was doing this, I now know, trying to rid myself of the discomfort of that uncertainty around who this kid was. And the reason that this particular episode proved to be somewhat profound for me was this. Maybe a week into doing this, rewinding, replaying, and repeating, if you will, in my head, the sequence, my mother came into my room, and she saw that I was still awake very late at night, and she asked why. And I said it was that kid that I couldn't figure out who had yelled hello to me. And my mother was very perplexed by this, and she said, we've talked about this, because I had been very concerned, and she said, chances are you may never know who that was, and that really agitated me. And she said, are you afraid that this kid was trying to hurt you? And I said, no. You're afraid he was trying to scare you? I said, no. And she asked me a question I couldn't answer, which was, why do you need to know? And looking back on things, I think that was the first time that I realized something was amiss, because I didn't know why I needed to know, but it felt like I needed to know. At the core of OCD, which is often called the doubting disease, is this intolerance of uncertainty. And even at that young age, at 7 or 8, I had so much problem processing the uncertainty around it. So that's my earliest memory of OCD.
When did you recognize that you needed to get help for this?
Like a lot of people with OCD, for reasons that I think a lot of doctors still aren't quite sure of, I had a period of dormancy. So I had a childhood OCD and a fairly significant case of that, but I had about 10, 15 years where I was essentially symptom-free. And then in my late 20s, life started spiraling out of control as I found myself not only mentally checking everything, but physically checking everything. So I'd have to return to my car over and over again to make sure that the parking brake was set. I'd have to go through my house and make sure all the appliances were off and the doors were locked and the windows were closed. Classic OCD. But I had no idea at that juncture.
Is that something that is typical where people will go for a long period of time symptom-free and then in their 20s suddenly flares up again?
Well, it could certainly happen. I think that probably about a third of OCD cases will probably start in early childhood. More often than not, I think for men, the typical onset is late teens, but oftentimes OCD is a variable course. It can show up at different times. There are peaks and valleys. Stress can be an exacerbator. I think there are certain developmental milestones in one's life, and going out and developing a career and being in the world in a different way can just be more stressful. So if you have OCD on board, could certainly trigger that. And I think if you look at people who don't have OCD, they oftentimes under stress might go back and check something. So probably all of us are vulnerable to these behaviors, but I think particularly in OCD you're going to see a greater magnification of things that probably all of us do. But I think the course of OCD tends to be variable. And I think, as Jeff mentioned, you could see it pop up, go away, come back under certain conditions or no conditions.
You realized that this was getting excessive and you needed to get some sort of help for it.
Very reluctantly acknowledged that I needed to get help because one of the things that sets OCD apart from just everyday anxieties, for example, is the degree to which it becomes debilitating. And I was spending so much of my day performing compulsions, checking things and rechecking things over and over again, that I knew I needed to get some kind of help. So I went to see a psychologist. And to be fair, I did not give this first psychologist much of a chance at all. I went in there with a real chip on my shoulder and basically told him he had 4 sessions to fix me. And lo and behold, he didn't fix me in 4 sessions. But interestingly, he was very quick to put a box around me. He said I had a fear of success. And I was at that point in my late 20s and working at a major market radio station, and everything was going my way except for this little part of my life, which was consuming me. And I thought, with psychiatric hang-ups go, fear of success sounded like a good one, so I went with that. Well, that didn't prove to be all that helpful of a diagnosis. And so I tried to soldier on for about 6 more months after that as life just became impossible. Went to see a second psychologist. And this psychologist, I'm sure, was very well qualified, but was a traditional talk therapist or a psychotherapist. And we did traditional psychotherapy week after week. And in my book, I've affectionately dubbed her Dr. How Does That Make You Feel? Because no matter what I would share with her, she would ask me how it made me feel, as opposed to trying to get at what was causing the problem. Fortunately, after about 3 or 4 months of doing this dance, she found that a very effective treatment process. She took vacation. As while she was on vacation, the investigative reporter in me came through, and I went to a bookstore and started combing the aisles, looking for something that fit my particular problem. And a wonderful book called The Boy Who Couldn't Stop Washing almost jumped off the shelf at me. Interestingly, I was not washing in those days. It was something about the words couldn't stop, that reference to compulsion, that proved to be just so right on for me. And very fortunately for me, the very first story in this book was the story about a gentleman performing some of the compulsions that I had been performing. And so I realized at that juncture 3 things. It was a very powerful moment for me. One, that I'm not alone, that there's at least one other guy who does things as seemingly crazy as I do. 2, that there's a name for it. The author called it Obsessive Compulsive Disorder. And 3, and most importantly, there's a treatment process. Interestingly, when I went back to see my therapist, her response was what? I'd like to think that the level of ignorance of this disorder is far lower at this particular juncture than it was then. But I still hear horror stories, and I'm guessing, Dr. Racklin, you've heard some of those stories too from patients.
I think that there's definitely a movement in having providers more knowledgeable about treating OCD, but I think there's still a lot of psychologists, psychiatrists, other therapists who don't have access, for whatever reason, to what we call the evidence-based treatment for OCD. So there's still a lot of how does it make you feel, and try not to think that, and substitute that with a positive thought, and fear of success, and those are all interesting interventions and approaches, but not supported by the research as being effective whatsoever.
How did this affect your personal life?
Well, in a number of very dysfunctional ways, some of which were downright comical, or are in retrospect. The irony of my life is I was living a very public life as a guy on the radio, and at this particular juncture in the early 90s, the ultimate irony was that I was being paid to be a field reporter, and as such, it was my job to drive the KCBS news van out to a breaking news story and cover the story. But as a person with harm obsessions and checking compulsions, driving was a huge challenge, and I'm sure you hear this pattern all the time. For somebody with my particular challenges, you drive over a pothole and you think to yourself, oh my gosh, what if I ran somebody over? What if that was not a pothole but somebody I ran over? So I turn my car around and check over and over again. So here I am in the KCBS news van, basically driving my car around the Embarcadero in San Francisco in circles, checking and rechecking everything, to the point where I ultimately had to start taking taxi cabs out to breaking news stories because the challenges of driving were so difficult. That was on the work front. On the home front, life became extremely challenging because, again, as somebody with harm obsessions, I identified for myself various classes of people that I deemed to be especially vulnerable. The elderly and children were among those, and I had a young child at home, and then before too long, 2 young children at home, and it was nearly impossible to be around them when they were with other children because of my challenges, and so it took a huge toll on my family life as well.
Joe, can you tell us a little bit about this, about OCD? What are obsessions and what are compulsions? You
Sure.
can just really get that.
Okay. Well, first of all, I think Jeff did an amazing job of describing his experience and really capturing all the elements that you see in OCD. And I think it's amazing that you're sharing this on the public level, because I think there's so many people who can identify with what you're going through, who don't know the names, the labels, who often feel isolated and ashamed because they're stuck in a certain pattern. Essentially what OCD is, it's an anxiety disorder. And anxiety disorders it's a condition that involves fear. It's essentially fear of thoughts, beliefs, and situations. And OCD in particular it's a condition marked by the presence of what we call obsessions and or compulsions. I say and or because you don't need both, even though the name implies OCD. Obsessions are basically persistent, unwanted ideas, images, impulses that are what we describe as ego alien. That's a fancy term. It just means this is not me. I don't want to be thinking this stuff. This is not pleasurable. It's distressing. It's intrusive, and it feels inappropriate. And the person does a lot to ward it off or to neutralize it. That's where we get into compulsions. Compulsions are behaviors. They can be observable behaviors like checking. They can be mental rituals, excessive praying, counting, reviewing. The purpose of the compulsion is to neutralize the anxiety that comes up in an obsession. So commonly you'll see hand washing as a compulsion that's designed to neutralize the obsession that comes up around contamination. Contamination, fears are very common. Probably checking, I'd say checking and washing are probably the most common categories of compulsions, but you've got other categories of OCD. I think in the media now we've got shows on hoarding, these extreme hoarding shows, and it's bringing to light how many people suffer from acquiring goods, whether they're valuable or not, and have difficulty getting rid of them. Other types of OCD that are not uncommon, people oftentimes don't talk about. There's a type called pure obsessional OCD, where the major struggle is unwanted, intrusive thoughts, feeling as if you might do something harmful or shocking to yourself or somebody else, and avoidance of those people because you fear that I might freak out or do something. There's other types of OCD involving symmetry and order. There's probably a newer variant that loads into some of the checking types as well, called just right OCD, where oftentimes something doesn't seem right for whatever reason. People that are observing this person struggling would see, it seems just right to me, but the person with just right OCD will oftentimes continue, whether it's checking or cleaning or doing whatever they need to do to make it seem just right. Jeff talked about we call it hit and run OCD, which is a common form of OCD where there's a fear that what if I ran somebody over, and you might feel a pothole or a sound or a noise or a sway in the car. The idea pops in your mind, so that's the obsession. The compulsion is going back to check. And the problem with checking is that it's very effective in the moment, but it doesn't help beyond the moment. And it may not even help that much in the moment. But going back to check, I imagine you'd feel like, well, I didn't hit anybody.
That's a pretty payoff.
I think I didn't hit anybody. Sometimes people say, well, I went back, I don't see anybody, but maybe the ambulance already came and took them away. Or maybe they got up and left, and I don't know. So the interplay of obsessions and compulsions is such that the compulsions, the checking, the mental rituals are designed to try to make the person feel better. But what they're really doing is they're reinforcing the fear and keeping the obsession and the fear alive, because we're acting in a way that is validating or verifying that the scary thought might be true. The diagnosis basically involves spending more than an hour a day of this. It's an arbitrary number, but we're trying to capture something that reflects that disorder being time-consuming, and that it involves some sort of distress or impairment. Distress, just anxiety, discomfort, impairment. Could be just the shrinking of one's social life, work life, spiritual life, anything where you feel like you can't be who you really want to be.
If someone were looking for a therapist to help them with, or someone to help them with this disorder, what kind of a therapist should they look for?
Well, probably not somebody who specializes in the fear of success. There's been, I think, a lot of developments in the past maybe 15 or 20 years. The Boy Who Couldn't Stop Washing was, I think, a very important book and signaled a shift in research and treatment of OCD, moving away from this talk therapy to trying to understand conflicts, and maybe something happened in your past that predisposes you to thinking this way. We've pretty much abandoned that because it's not effective. And we've moved more into what we call cognitive behavioral treatment, cognitive behavioral therapy. And this is a collection of treatments that's really looking at the cognitive piece has to do with how do people think, what are the beliefs, what thoughts pop into their mind, and how much credence do they give those. A lot of times in OCD, when somebody who hasn't received treatment, they're usually buying into the thoughts. I am what I think. They get a scary thought. For example, I may have run somebody over. Oftentimes there's no sense that this is just a thought. This is just anxiety. So the cognitive part of cognitive behavioral therapy is helping people identify OCD as OCD, identifying the thoughts as anxiety, helping them to challenge them, looking at evidence. How many people have I run over? How many times have I really gotten contaminated and killed my family because of germs I brought home from work? It may seem like simple questions, but sometimes we don't ask those. So we want people to look at evidence. And then the behavioral part of cognitive behavioral therapy has to do with changing our relationship to what we do, which allows us to challenge our thoughts. And that's essentially, it's either doing things that you're not doing or not doing things that you are doing. Peeling back those compulsions, not checking, not going through the mental rituals, which what that does is, going back to how does it make you feel, if you're doing cognitive behavioral therapy, it's probably going to make you feel bad initially, because what we're trying to do is help people desensitize or habituate to the presence of these uncomfortable thoughts.
Are there other therapies for OCD? What's the most recent and current thinking about this?
Well, I think, as Jeff mentioned, the exposure with response prevention, I think that should really be the main focus of any treatment. There's some other, I think, very effective augmenting treatments as well. There's what we call metacognitive approaches. I think the most popular is Jeffrey Schwartz's brain lock, which essentially is about changing, it's probably a good path towards changing the way you think about your OCD. It's based on the biological model that OCD is probably due to biology more than anything else. It's about relabeling thoughts. When you get a scary, obsessive thought, instead of trying to fight it, you say, this is my OCD. You reattribute it. I'm having these thoughts. Why? Because fear of success? Because I'm a bad driver? No, because I have OCD. Then it uses some mindfulness strategies to help people re-engage in the moment and to put off compulsing, but to use the moment not as a distraction, but as an anchor, because that's really where we should all be. Most of us aren't in the moment for whatever reason, but it's using the moment as a way to re-anchor. And then the fourth step is called the revalue step, which is just basically saying, for the vast majority of people with OCD, there's really no reason why you can't have a full life. And that you can have these thoughts, you will have these thoughts, but don't let these determine meaningful activities. Don't let these short-circuit you. Another probably newer treatment, I think it's just a new generation of the cognitive behavioral treatments and works very well with them, is something called acceptance and commitment therapy. And this is a treatment that was developed by a psychologist named Stephen Hayes, who's in University of Nevada in Reno, and he himself struggled with anxiety. Almost didn't finish graduate school because of that. So a lot of his theory came out of his own struggle. But he uses the acceptance part. It's called acceptance and commitment therapy, or ACT, and the acceptance piece basically allowing thoughts to be there. Not saying I want to have these thoughts, but just realizing that the struggle to not have these thoughts just means I'm going to have more thoughts. So it's a strategic acceptance. It's using what we call diffusion techniques. So when these thoughts pop up, it's relating them differently, sometimes through humor or observation, and then again using mindfulness techniques of anchoring yourself in the present, using a call a wiser mind perspective. So even if you have that chatter going on, anybody with OCD, if you develop your perspective enough, you can wrestle out a little non-OCD part of yourself that can observe and watch and just comment on your own thinking. And then the commitment part of ACT therapy is really interesting too, because Stephen Hayes talks about the importance of living in accordance with your values, and that may bring you into conflict with a lot of things. And some of those things, if you have OCD, will be your anxiety. It means if you want to live fully in the world, whether it's work, relationships, how you just want to be with people, it may mean you have to confront driving. It may mean that you have to deal with contamination. And so avoidance, if you allow avoidance to dominate your life, you're moving away from your values. In ACT therapy, the hardcore ACT therapy providers would say, in a way, we don't care how you feel. We're more concerned about what you do. Are you living a full life? And if you are, that's more important. Because not having anxiety, not having struggle, not having trouble, that in alone doesn't make a full life. That doesn't mean you're doing anything important. In fact, maybe not having anxiety isn't a good thing, because it could end up on your couch.
Jeff, you've written a couple of books, and I think some of the things you said sound like things that you said in your books. Could you tell us about them?
Sure. Well, my first book, Rewind, Replay, Repeat, is a memoir, and I share in that my rather circuitous path to wellness. I share my earliest memories. I share my downward spiral in my late 20s in terms of life falling apart because of the OCD, and I share my misadventures in the mental health world along with my successes. The second book grew out of my travels. I published the first book about 3 years ago, and I started traveling the country, first as book tour promotions and later as a representative for the National OCD Foundation. And I became fascinated with how many people could relate to OCD that don't have OCD. That core what-if question followed by counterproductive measure to rid ourselves of anxiety cycle. And so I wanted to explore that. And late last year, I published my second book, When in Doubt, Make Believe. And in that book, I draw parallels between what those of us with OCD do to deal with our uncertainty and our anxiety, and what the rest of the world can learn from that. My hypothesis is not that everybody has a touch of OCD by a long shot. OCD is a very narrowly defined biological brain disorder. But that said, I've come to find that everybody has their own voice of doubt, their doubt bully, as I call it. And I think there are a lot of lessons to be learned from those of us who've battled this and those of us who treat in terms of the notion of exposure therapy.
I have questions for both of you, actually. What can the family members and friends do if they know somebody in their family has OCD?
Well, I'd say first to get educated and be compassionate. I think a lot of times family members they may be well-intentioned, will tell people, well, just stop doing that, stop having those thoughts, stop doing that behavior. And I think if it were that easy, people would do that. So I think getting families educated on what's helpful and what's not, how to be supportive without also becoming a sort of a proxy compulsive person, where you don't want to end up doing compulsions for somebody to say, like, well, we got to get going, let me check for you, or I went, the gathering appliances are off. That doesn't help. So we want family members and friends to know how to really be effective in terms of how to be supportive, how to know that person's operating instructions. And there's a lot of good information. I think a lot of certainly reading one of Jeff's books, I think would be really great. A lot of the more common OCD workbooks will have a section on families. So I think it's really compassion, it's education, and not falling into the trap of compulsing or providing reassurance.
Anything to add to that?
Yes. The very first phone call I made when I realized the correct diagnosis through the book, The Boy Who Couldn't Stop Watching, was to what was then called the OC Foundation, and is now the International OCD Foundation based out of Boston. And one of the great serendipitous arcs of my life is that I'm now privileged to serve as their national spokesperson and sit on their board of directors. It's my real passion to work with this organization to raise awareness. Great website, simply ocfoundation.org, and it's a great place for people to turn in the privacy of their own home to go online and get everything from background articles to a tool for finding a local therapist in their area who specializes in OCD. So I would encourage families and potential OCD sufferers to check out that resource as well.
Okay, good. Thank you.
And I'd say also, it's a great point about finding a specialist. I think if anybody seeks out a provider, is to ask them, do you treat OCD? And how do you do it? What are your methods? What are your approaches? That's key, because you could have a very well-intentioned therapist who is going to focus more on understanding how did this happen, let's deconstruct your childhood, let's look at these events, and very interesting stuff, but really not helpful. So we want people to get hooked up with the right provider.
Jeff has already mentioned some resources, International OCD Foundation, ocfoundation.org. There are a couple of other websites, OCD Online website, so it's ocdonline.com. And the largest self-help support site for OCD is www.stuckinadoorway.org. You can see that on your screen. And of course, Jeff Bell has his own website, beyondthedoubt.org, and the books that he has written, Rewind, Replay, and Repeat, and When in Doubt, Make Believe. So I want to thank you, Joe, and thank you, Jeff, for being on the program today and helping people. And I'll close with these words by the Reverend Wayne Arneson. Take courage, friends. The way is often hard, the path is never clear, and the stakes are very high. Take courage, for deep down there's another truth. You are not alone. Thanks for watching. I'll see you next time.